Well, hello everyone, and welcome to our second lecture in the Certificate of Professional Practice in the Epidemiology and Control of Non-Communicable Diseases. As you already know, my name is Professor Brian Mangum, and I'm very excited to be providing you with this ongoing series of lectures on epidemiology and specifically on the epidemiology of non-communicable diseases. So this video lecture, just like the last one, will take about an hour to complete. And it's going to provide you with an overview of non-communicable diseases and their related risk factors. Now, after you complete this video lecture, there's going to be a set of instructions at the end on how to document your participation towards the Certificate of Professional Practice in the Epidemiology and Control of Non-Communicable Diseases. And in particular, I'm asking that you'll send me 3 things that you learned, 3 of your own little learning objectives that you took away from this lecture when you communicate with me. And as always, I just want to give my special thanks to the U.S. Centers for Disease Control and Prevention for the open source material from which these lectures are based. And I also want to give my thanks to the Pacific Island Health Officers Association and the School of Public Health and Primary Care at Fiji National University, and also the Public Health Training Program at the College of Micronesia, FSM, all of which have come together to provide these series of lectures and these certificates of professional practice for you, the medical, dental, nursing, and public health workforce across the Pacific. So this lesson is going to provide you with an overview of the 4 priority non-communicable diseases and their related risk factors. And what we're going to talk about is the World Health Organization has identified 4 primary target NCDs that they want all public health employees and medical personnel across the globe, but especially here in the Pacific where we have such a high rate of NCDs, to focus their efforts on. So that's why we're going to introduce these 4 to you today as burgeoning young NCD epidemiologists. So at the conclusion of this lecture, you should be able to describe the following elements, and in particular, you should be able to describe them for your country and your region. You should be able to talk about the burden of disease of the 4 major NCDs, and I have specific tables towards the end that list those by Micronesia, Melanesia, and also Polynesia, depending on your specific area across the US API. And you should be able to discuss how these risk factors affect the burden of disease across the Pacific. And you should also be able to talk about the definition and characteristics of the different NCDs. You'll be able to talk about global trends in NCDs. You'll be able to give a definition of the risk factors for NCDs, and you'll also be able to give a definition of the metabolic risk factors for NCDs. And what you'll see is that they are closely linked, although they are just a little bit different. You'll be able to discuss the common risk factors for NCDs, and in fact, I'm hoping that's one of the take-home lessons that you'll get from these lectures, is that many times the different NCDs, such as cancers and chronic respiratory illness and so on and so forth, have common risk factors. So if we can apply prevention methods and appropriate epidemiological surveillance methods to those common risk factors, then we can reduce the burden of multiple NCDs at the same time. And then the final thing that you'll be able to do is you'll be able to define and discuss the global burden and health effects of the 4 leading NCDs, the 4 lifestyle risk factors, and then the 4 metabolic risk factors that are associated with those. So let's just begin this lecture by defining non-communicable diseases. Now, this is something we did in our previous lecture as well, so this should be a refresher for you. So as you may recall, for the purpose of this course, we're calling the chronic diseases. Now remember, chronic diseases is the term we used to use. We're simply going to refer to them as non-communicable diseases, or NCDs. So we define an NCD as a chronic condition that does not result from an infectious process. And it also has to have a prolonged course. It's not going to resolve spontaneously, and there generally is not going to be a complete cure available, or a complete cure is rarely going to be achieved for these diseases. Now, there are some limitations to the old definition of chronic disease, and an example of that would be HIV. Now, HIV is chronic condition because it's of a long duration and it's not curable, but we would not actually call HIV an NCD because it has an infectious etiology. Now, if you recall, we laid out several characteristics of NCDs, and remember they have a complex etiology, meaning there's a wide variety of reasons that contribute to the presence of these diseases in the population, such as lifestyle risk factors, genetics, and also large-scale economic and nutritional trends that we see globally. Okay, so there's a complex etiology that underlies them. Okay, they tend to have that long latency period that we've talked about in the past. In other words, they tend to develop over a course of a number of years, sometimes even over decades, okay, before they actually become a noticeable disease that's diagnosable. They are non-communicable, like we talked about, and they do tend to go on for a long period of time. And of course, they tend to result in some type of functional impairment or a disability. And a wonderful example of that would be like type 2 diabetes resulting in an amputation, for example, resulting in a disability that would be difficult to deal with a lot of times in our resource-limited environments that we have out here. Now, NCDs, like we've mentioned, can include the diseases that we normally think of, and that would be things like type 2 diabetes, cancers, cardiovascular disease, and so on and so forth. And you can see we have a number of those listed on the slide there. But it can also include chronic mental illnesses such as schizophrenia, bipolar disease, and so on and so forth. And it can include injuries which have an acute onset. So when we say an acute onset, we're talking about rapid onset. So in other words, an individual is in an automobile accident and they receive a traumatic brain injury, or they become a quadriplegic or something like that. And the other thing to keep in mind is that a lot of these non-communicable diseases are going to be followed by either a prolonged convalescence or recovery period, okay, or they're going to be followed by impaired function that's going to stay with that individual for life. So the individual that's involved in an automobile accident and becomes a TBI patient, that's not something they're necessarily going to get better from. They're going to have impaired mental functioning the rest of their life. Same thing with the diabetic that has an amputation, okay? That's going to be something that's with that individual for the rest of their life. Now, the other thing to keep in mind is that all of the NCDs are going to cause premature morbidity, all right? So in other words, early onset of the disease or the disability, and they're also going to result in dysfunction, and to a great extent, they're going to reduce the quality of life of our patients, okay? All bad things, all right? Just underscores the reason why prevention is so important. Now, they usually develop and progress over longer periods of time, okay, which we've talked about, and they're going to have that insidious or unnoticed development. And then once again, once they're present, there's a protracted period of impaired health and lack of function for these individuals. So here on this slide, you can see we have a list of some examples of non-communicable diseases. Now, keep in mind that this is not an exhaustive list. It's simply some examples. So what do we see here? We have cardiovascular disease, and that would include like coronary heart disease and stroke. Okay, we also have cancer, and in particular, that would include things like prostate cancer, breast cancer, and lung cancer. And then we also see we have chronic respiratory diseases such as COPD and asthma. And then, of course, we have diabetes, and in particular type 2 diabetes. And then we also see we have chronic neurological disorders such as Alzheimer's, dementia, multiple sclerosis, and so on and so forth. And of course, arthritis and some of the musculoskeletal disorders, okay, and then those unintended injuries that we've mentioned before, such as from traffic accidents, violence, and so on and so forth. Now, the first four, that would be the cardiovascular disease, cancer, chronic respiratory disease, and diabetes. These are going to be the most prevalent NCDs in the world, and consequently, they're going to be those 4 WHO focus NCDs that I've mentioned already in the lecture. So for the remainder of the lecture, that's what we're going to focus on. We're going to focus on the cardiovascular disease, the different types of cancers that are associated with NCDs, chronic respiratory disease, and then also diabetes. Now, it's important to know that 80% of all the NCD deaths occur in low to middle income countries, such as the Pacific. Okay, and in fact, we have the highest burden of of any region in the world in terms of NCDs. So it's very important for us to get a really good handle on the epidemiology of these NCDs, because without good epidemiological evidence, then we can't really develop good control programs. And that's one of the great benefits, I'm hoping, of this series of lectures, is to give you that background in epidemiology that you can go out and make better use of both collecting, analyzing, interpreting, and also making use of epidemiological data on NCDs. So let's take a look at the projected deaths between 2015 and 2030 as related to NCDs. So this graph represents the proportion of total deaths that are attributed to a particular cause. So for example, in low-income countries, the proportion of death due to cardiovascular disease is projected to increase between 2015 and 2030. Now this projected growth will be seen in high, middle, and low-income countries, so all across the board, but look at the differences in how quickly the deaths will increase. Not only will high-income countries see lower numbers of deaths, but the projected increase is also going to be smaller. Now, whereas middle and low-income countries have a high burden and will see a higher increase in the number of deaths from NCDs. Now, you should also notice that the deaths from infectious diseases, which are already very low in developed countries, will also decrease even further. And at the same time, we will also see a decrease in infectious disease rates in the low and the middle income nations. Now, this does not mean that we need not worry about infectious diseases. Rather, here in the Pacific, we're going to continue to battle a dual burden of infectious as well as non-communicable diseases, particularly as we continue to see the reemergence of diseases such as Zika virus, which is now in a large percentage of the Pacific Islands. So it's about the middle of March 2016 right now, and Zika is rapidly spreading across the Pacific. It's been identified as being present in Fiji as of this week as well, and once it enters a large population center like Fiji, which has almost 1 million people, then we're probably going to see it spread even further across the Pacific. Now, if you're interested in Zika, you can actually go to my YouTube page, and there's a continuous professional development lecture entitled Zika Virus in the Pacific and Public Health, What You Need to Know for Practitioners. If you want to, go watch that, send me an email, and I'll send you a certificate of professional development for that activity. Anyway, back to non-communicable diseases, okay? So what's going to cause this increase in deaths from non-communicable diseases, particularly in the low and the middle income countries? Now, by the way, if you look at the World Bank definition for what constitutes a low and a middle income country, the entire Pacific, the US API, and the other island nations out here, we all qualify as low income countries, okay? So what's going to cause this increase in deaths from NCDs? Well, you should already know this, all right, and the answer is primarily going to be obesity and diet, okay, which was now the concept of obesity and diet is actually much more complex than simply shaking our finger at people and saying, you know, you're eating the wrong foods, why don't you eat better foods, more fruits and vegetables, why don't you exercise more, okay? Rather, it's a complex relationship between economics, politics, education, and so forth that places our populations here in the Pacific in a situation in which they may not have the resources they need to make healthy choices. And I actually have a online about 35-40-minute lecture that deals with that, and I'll give you the link to that a little bit later in this discussion as well. Okay. Now, you may recall in our previous video that we defined what a risk factor was, okay? So here is a quick review of what a risk factor is. So a risk factor is an aspect of personal behavior or lifestyle, an environmental exposure, or a hereditary, that's genetics, okay, or a hereditary characteristic that is associated with an increase in the occurrence of a particular disease, injury, or health condition, okay? So that's just a quick review of how we defined risk factor. And then what you probably also remember is that we also talked about modifiable risk factors and non-modifiable risk factors. So here on this slide, let's just do a quick little review of what a modifiable risk factor is. And like I said, we talked about this in our last video as well. Now remember, it is important for us to think about modifiable risk factors. And it's important for us to think about these modifiable risk factors since these are things that we can change to alter disease rates in the at-risk populations that we serve. Now WHO has determined that the 4 priority modifiable risk factors that can be altered to reduce the rates of global NCDs are physical inactivity, tobacco use, alcohol use, and altering diets. And in particular, when they talk about altering diets, they're talking about altering the fat consumption, altering the sodium consumption, and then increasing the consumption of fruits and vegetables. Now, we know that by reducing the rates of tobacco and alcohol usage and increasing the physical activity and the consumption of healthy foods, then the rates of NCDs can be reduced, and that's particularly true here in the Pacific. Now, once again, it's overly simplistic to put it that way because really it's a larger scale issue looking at the economics and the politics and ensuring that people have significant amounts of health literacy to understand the risks from NCDs and also have economic and political opportunities so that they can have incomes where they can afford healthy diets, okay? But like I said, that's a discussion for another lecture. So here we're going to keep it nice and simple. And like I said, we're just going to focus on the fact that WHO has identified these priority NCDs, and they've identified the priority changes that we need to see in our populations to reduce these NCD rates. Now, you may also recall that we discussed non-modifiable risk factors, and those include age, gender, ethnicity, and family history. And once again, when we say family history, we're simply referring to genetics, okay? Now, remember, these are the things that we cannot change. So it's important in the populations that we serve that if we see someone who has a family history of risk, okay, or comes from a specific ethnic group with an increased risk factor, that the focus be placed on modifying as many lifestyle issues as possible or as many modifiable risk factors as possible to offset the non-modifiable risk, okay? Now, I also want to introduce the term metabolic risk factors. Oh, and I just noticed something. I apologize. This is labeled slide number 12, when in fact it should be labeled slide number 11. But I do see that the next slide is correctly labeled, so just please note that, okay? So like I said, we need to introduce this concept of what a metabolic risk factor is. Now, as many of you probably know, and just as a quick review, metabolic simply refers to the biochemical processes involved in the normal functioning of the body, such as our metabolism, our production of hormones, and so on and so forth. Now, certain modifiable behaviors, such as overconsumption of fats and sugars, can lead to metabolic changes. Now, WHO has identified 4 of these metabolic changes which are linked directly to NCDs and which can be altered through lifestyle changes. So in other words, through the use of modifiable risk factors, we can modify these metabolic risk factors. Now, the metabolic risk factors include hypertension, which simply means raised blood pressure, okay, and that's a risk factor for end-stage renal disease, stroke, and heart disease, and so on and so forth. Hypercholesterolemia, which simply means raised cholesterol levels, and of course that's also associated with an increased risk of coronary vascular disease, elevated blood glucose or blood sugar levels, and that's associated with an increased risk of type 2 diabetes and so on and so forth. And then the last one is overweight and obesity, generally taken as like a BMI score. And as you know, overweight and obesity is kind of the central tendency of so many of the NCDs that we deal with. It's a risk factor for cancer, for diabetes, for cardiovascular disease, and so on and so forth. And so once again, and I know I keep saying this, I do hope that one of the take-home messages you learn is that when it comes to epidemiology and control of NCDs, if we can control a few of these priority risk factors, then we can control many of the NCDs as well. So now we're going to go ahead and we're going to talk about the 4 leading non-communicable diseases as have been identified by WHO, and we'll talk about them one at a time, and that's going to be the cardiovascular disease, diabetes, and we'll talk about the different types of diabetes, but in particular we're going to talk about type 2 diabetes, okay? And we'll talk about cancers that are associated with NCDs, so we'll talk about breast cancer, prostate cancer, and also lung cancer, and then we'll also talk about chronic respiratory diseases, and that'll include COPD or chronic obstructive pulmonary disease, as well as asthma. So the first priority NCD is cardiovascular disease. Now CVD is caused by narrowed, blocked, or stiffened blood vessels that prevent your heart, your brain, or other parts of your body, such as your kidneys, from receiving enough blood. Now, I do want you to note that some congenital, and when I say congenital, I just mean present at birth, some congenital heart conditions can be corrected or cured with surgery, while others have a prolonged course. So while technically congenital heart conditions are a type of cardiovascular disease, we're not actually going to discuss those in this video. So, CVD includes coronary heart disease or diseases of the blood vessels supplying the heart, such as a coronary blockage, cerebrovascular disease, such as a stroke, which is a disease of the blood vessels supplying the brain. And then we have peripheral arterial disease, which is a disease of the blood vessels supplying the arms and legs, such as might be the cause of an amputation in a diabetic. And finally, the congenital heart diseases that I've already mentioned, which are not going to be the focus of this discussion. Now, CVD is the #1 leading cause of death worldwide in both developed as well as developing countries. Now, an estimated 17.3 million people died from cardiovascular disease in 2003, and that actually represents 30% of all global deaths. Now, this is clearly a huge number, but the true takeaway message here is that 80% of all the deaths from cardiovascular disease actually occurred in low and middle income countries. Now, a quick search of the World Bank income rankings, like I mentioned already, will show you that the entire Pacific fits within the category of being low-income nations. We also have the highest burden of NCDs in the world, and that includes one of the highest burdens of cardiovascular disease in the world as well. So clearly, it's a significant problem for us out here in the Pacific. So based upon what we've discussed thus far, what are going to be the modifiable and non-modifiable risk factors associated with cardiovascular disease? Now, as you can see, the bulk of the modifiable risk factors involve lifestyle changes in management, such as changes in diet and exercise level. But there are also metabolic risk factors present as well, including hypertension and hypercholesterolemia. Now, these are directly linked to poor lifestyle choices, such as eating too many foods that are high in sodium and fatty foods in the diet, and so on and so forth. So if we can alter the lifestyle modifiable risk factors, then we can, in many instances, alter the metabolic risk factors as well. Now, it should be noted that lifestyle management is going to be the end goal, okay? But that there may be the need to do medical management during the time in which we're implementing a program of lifestyle change. So, for example, a patient with primary hypertension who is obese and has an unhealthy diet should receive counseling on lifestyle management. But they should also receive hypertension medication, right, such as an ACE inhibitor, a diuretic, something along those lines, okay? And they should probably also be receiving statin drugs to lower their risk of hypercholesterolemia at the same time. So in theory then, as the patient loses the weight and engages in exercise and they control their lifestyle risk factors, okay, then the need for medication will go down. But I do think it's important in public health to realize that we have to work closely with medicine in terms of biomedical interventions as well as lifestyle management. And for our clinicians out there, you know, with primary hypertension, sometimes even if we reduce the obesity, even if we reduce the amount of salt that individuals taking in, sometimes the blood pressure doesn't come down and the individual has to stay on a diuretic or something like that for long term. Now, I also want you to note that the other modifiable risk factors, including low socioeconomic status, psychological health, mental illness, and alcohol abuse, are also present here. Now, those who lack the economic assets needed to engage in healthy lifestyles, or who lack the basic health literacy levels to understand the need for change, are not going to be able to comply in many instances with the lifestyle modifications that we want them to undertake. As such, it's going to be critical that any interventions be multifaceted, okay, and that they focus on not only educating the public about healthier lifestyles, but they also focus on raising the economic status of a population as well. Now, this can be seen in developed countries where those of higher income and educational levels tend to have lower rates of both NCDs and communicable diseases, and that's owing to simply access to resources such as high quality and healthy foods, as well as screening and prevention activities as well. Now, for an in-depth discussion of the socioeconomics of nutrition and obesity and NCDs, I really would encourage you to watch a video that I have on my YouTube channel. And if you're looking at the transcripts of what we're talking about today, that link is there. It's called Global Economic and Nutritional Shifting: Roots of the Global NCD Pandemic. I know quite a few of you have done that activity already, but as with all of my online activities, if you'll go listen to that and you'll send me an email, I can send you a certificate of professional development for that. Now, I do want to mention there's also a strong linkage between NCDs and mental illness. Now, those with mental illness represent a disproportionate number of those who smoke, and hence there is a much higher rate of chronic lung disease among those with mental illness. Now, those with mental illness also represent a large percentage of the population who abuse alcohol, and hence have higher rates of social dysfunction that comes along with alcoholism, as well as things like liver disease and cirrhosis, okay? Plus, those with mental illness tend to have less stable employment and living conditions, and thus further predisposing them to non-communicable diseases. Now, just like the Global Economic and Nutritional Shifting video, I have a video you can watch that explores the connection between non-communicable diseases and mental illness, and that's entitled No Public Health Without Mental Health: Integrating Mental Health into the Public Health System. So once again, that's available on my YouTube channel. I can send you a CPD certificate if you watch that. So now that we've talked about cardiovascular disease, let's talk about diabetes. Now, diabetes is a chronic disease that comes about when the pancreas does not produce enough insulin, or when the body cannot effectively make use of the insulin that is being produced. Now, insulin, as you already know, is a hormone produced in the pancreas that helps the body take glucose or sugar from the blood and then use it to make energy. Now, failure to produce insulin, or the failure of the body to use the insulin properly, can lead to raised blood glucose levels, known as hyperglycemia or high blood sugar. Okay. Now, when this occurs over a long period of time, it damages the body, including the various tissues such as the kidneys. Now, there's 4 different types of diabetes. Okay, and that's going to be type 1 diabetes, and as you know, type 1 diabetes is primarily hereditary. Then we have type 2 diabetes, which is the diabetes that we're going to be talking about today, and the one that's a primary public health importance. And we have gestational diabetes, and then we also have what we call prediabetes, which is impaired glucose tolerance. Now, type 2 diabetes, as you know, was previously called adult onset or non-insulin dependent diabetes. Now, in adults, type 2 diabetes is going to account for between 90 and 95% of all cases. Now, while it used to be seen only in adult populations, it's now seen in all age groups due to a rise in unhealthy diets worldwide. And it usually begins as insulin resistance, where cells do not properly use the insulin that's being produced by the pancreas. And then as it progresses and as the need for insulin rises, the pancreas gradually loses its ability to produce the needed insulin, and then it transitions over into type 2 diabetes. Now, gestational diabetes is a type of diabetes associated with high birth weight in children, sometimes associated with obese mothers, and generally resolves following the delivery of the child. So we won't be talking about that. Okay. Now, I actually have another video you can watch entitled Type 2 Diabetes and Public Health: Correlates and Prevention. You can find that on the YouTube page, and once again, happy to provide you a certificate of professional development if you go out and watch that. Now, as you can see from just a quick glance at this slide, diabetes is a major public health issue, particularly type 2 diabetes, which is preventable based upon what? Appropriate lifestyle choices. Now, here in the Pacific, we have a very large burden of type 2 diabetes, much of which is undiagnosed. Now, this undiagnosed burden will lead to significant morbidity in the long run, including the need for dialysis and end-stage renal failure treatment. And as you know, in many of our jurisdictions, okay, we don't have the equipment or the other resources that we need to provide dialysis. Okay, so what does that mean? It simply means that we need to place a greater burden on prevention within our healthcare system. Okay. Now, prevention that focuses not only on traditional public health methods such as health promotion, but we also want prevention that is sustainable and is focused on solutions designed to give our people here in the Pacific the economic and social resources they need to live healthy and productive lives. Because it really doesn't do us much good to wag our finger at people and tell them to eat better, exercise, and so on and so forth when they simply don't have the economic resources that they need to do that. Okay, so once again, prevention should focus on traditional public health methods, but it also needs to focus on development. So what are the risk factors for type 2 diabetes? Well, you notice that some are non-modifiable, meaning that if you have a family history of diabetes, then you're at increased risk, and there's not much you can do about that, okay? But from a public health and a medical education standpoint, those who have non-modifiable risk factors should receive extra education on the need for lifestyle management as a means of mitigating the role of genetics, age, and so on and so forth. Now, other risk factors are going to be modifiable. And just like our discussion of cardiovascular disease, you can see that changes in lifestyle risk factors, particular diet and exercise, also lead to modification of metabolic risk factors such as decreased hyperglycemia. Now, I also want you to notice that the same other risk factors, such as socioeconomic status that we mentioned with cardiovascular disease, are also going to be present here. Now, one of the major take-home messages for these series of lectures that I keep talking about is that long-term prevention and control of non-communicable diseases must involve economic development for our populations. Otherwise, health promotion simply becomes a short-term solution and not always a very effective short-term solution at that. Now, you're probably also noticing the trend to include obesity and overweight as a risk factor for the target NCDs that we're discussing, and this is very, very true. Obesity, please remember this, obesity sits squarely at the center of the NCD pandemic that we're facing here in the Pacific. We are the heaviest region in the world, and hence we are the sickest region in the world as well. How sad to think about that. And for those of you who have listened to my lectures before, you know I'm a Palangi, I'm a Howley, I'm a white guy, okay? But at the end of the day, I consider myself part of the Pacific. I consider this my home. I'm raising my family here. I'm living here. And so when I see that we're the heaviest region in the world and that we're the sickest region in the world, I think how truly, truly sad. We're such a strong people, and we have a strong culture that dates back thousands and thousands of years, and yet NCDs are overwhelming us and they're slowly destroying us. So if we can control obesity, then we control NCDs. It is the epicenter of what is destroying the Pacific right now. Please remember that obesity control programs are truly the biggest bang for your dollar approach here in the Pacific. You design a program to control obesity, you control so many other things. Okay. Now, not surprisingly, I have 2 video lectures available on my YouTube site. And if you need to find my YouTube site, it's simple. Go to YouTube and Google Brian P. Mangum, one word, okay, and I come right up. All right, but I do have 2 CPT lectures that you can go and watch on obesity. One entitled Childhood Obesity Programs, Comparative Effectiveness of Interventions, and that's a particularly good one because if we can prevent a child from becoming obese, we have prevented an adult from becoming obese. And then the second one is called Obesity Prevention and Control, the Healthy Communities Approach, and that looks at how we can get the community involved, what changes we can make in the design and the physical availability of resources in a community to help control obesity. Okay, so now we've discussed cardiovascular disease and diabetes. Let's take a look at cancers. Now, cancers begin at the cellular level. Now, normally cells grow and they divide to form new cells as the body needs them. And when the cells grow old, they die. It's called apoptosis. Okay, and as those cells die off, they're going to be replaced by new cells. But sometimes the process goes wrong and the new cells form when the body doesn't need them. And at the same time, the old cells don't undergo that programmed cellular death that we rely upon. Now, these new cells, right, they join together and they cause the masses of tissue that we sometimes call a tumor, or that sometimes we might call cancer. Now, tumors can be benign, all right, and when they're benign, they're not actually a cancer. They're not going to cause harm, or they can be malignant, meaning that they are cancerous and they do cause harm. Now, like I said, benign tumors are not cancer, and a lot of times your benign tumors can be removed. And the other thing to remember about benign tumors is that they usually do not grow back, they don't tend to spread to other tissues around them, and they don't tend to spread to other areas in the body. Now, your malignant tumors are a cancer, and they can be life-threatening. Okay. Now, malignant tumors can sometimes be removed, not always, depending upon how far they've spread, okay, and whether or not we identify them early or not. Okay, but sometimes even if we do remove them, they may grow back, or they might have the tendency to invade surrounding tissues, or they might do what we call metastasize, meaning they spread to other areas of the body. Now, once again, all right, looking at this slide, we see that cancer, like cardiovascular disease, is going to be a significant source of both morbidity and mortality in the world, and hence it's going to be of significant public health concern. In particular, I want you to note here the high burden of cancers in the developing world, with 70% of all of our cancers occurring in low to middle income nations, such as we have here in the Pacific. Now, we also need to note that 30% of cancers can be attributed to lifestyle factors such as the food we eat, the exercise, the environmental exposure. Do we live with a smoker? Do we work in a factory where we're exposed to certain chemicals and so on and so forth, okay? But a lot of those 30% of cancers can be attributed to lifestyle choices that are preventable. So in other words, like I said, the foods we eat, okay? Hence, there is the potential to prevent a large number of cancers before they even occur. Now, much like diabetes and dialysis, we know that we don't always have the resources we need to treat cancers in our different jurisdictions. And thus, what do? We spend large amounts of money to fund off-island referrals to places like Hawaii, the Philippines, New Zealand, even sometimes to places like Thailand or as far away as India to treat these things. Now, this is money in theory that could be saved if we were able to prevent cancer through lifestyle modifications, and then that money could be put to other uses such as funding public schools and colleges and so on and so forth. So remember, think of prevention. Not only does it save lives, but it saves money that can be used to develop our lovely Pacific in other ways as well. So let's talk about some specific types of cancer and their burden out here in the Pacific. And we'll begin with cervical cancer. Now, first, it's interesting to note that 99% of all cervical cancers are attributed to genital infections, and not just any genital infection, but genital infections with HPV, the human papillomavirus. Now, you probably know that there's now a vaccine available for HPV, okay? So ask yourself the question really quick, is this vaccine available in my jurisdiction as a way of preventing cervical cancer among young women? And if it is available, am I making sure that the young women who need access to it are getting access to it, knowing that 99% of cervical cancer cases could be prevented with access to the HPV vaccine? And if it's not available in my jurisdiction, why? And what can I do as a public health provider or a medical provider or a nurse educator or something along those lines to see that the HPV vaccine is brought to my jurisdiction? Because like I said, 99% of all cervical cancers are linked with HPV, meaning there's significant area for improvement in the rates of cervical cancer by simply using the vaccine. So let's look at this chart. So looking at this chart, you can see that globally the rates of cervical cancer in Polynesia and Micronesia are in the middle range, okay? But these remain significantly higher than more developed areas of the world, such as Europe and the United States. So as such, we're once again left in a position of understanding the importance of prevention, and in particular the use of effective prevention tools such as vaccinations as a means of controlling cervical cancer. But we should also note that there are other risk factors for cervical cancer which may either stand alone or act in concert with exposure to the HPV virus. And these include things like smoking. Now, smoking is a modifiable risk factor that lends itself well to public health programs such as legislation. All right, to put tougher laws on who can buy cigarettes, who can import cigarettes, how can cigarettes be advertised, and so forth, okay? So smoking is really responsive to regulatory changes, all right? So we make sure that people have access to the HPV vaccine, we make sure that the rates of access to cigarettes and smoking go down, and we can really have an impact on the rates of cervical cancer here in the Pacific. A couple of other things that are associated as risk factors for cervical cancer include poverty, which we've discussed previously in this lecture as being associated with an increased risk of NCDs, and which is amenable to development programs, okay? And we also know that access to screenings such as Pap smears and other methods is a significant risk factor, all right? So do we have a population that understands the needs for Pap smear? Is it a population that's been educated to remove the social stigma associated with talking about Pap smears? And do the people have access to culturally appropriate screenings, all right, where they can go in and actually get the Pap smears done? Now, all of these elements that are coupled with the HPV vaccine can really reduce the incidence of cervical cancer here in the Pacific. Now let's talk about lung cancer. Now, lung cancer is the leading global cause of cancer deaths, and it accounts for about 1.5 million deaths annually, and it tends to impact men more than women. Why? Well, we do know that men tend to smoke in higher rates than in females, although we also know in many developing areas of the world, advertisers are now targeting females in terms of trying to get them to start smoking. So let's look at this graph. Now in this graph we see that for Polynesia and Micronesia there are relatively high rates of lung cancer deaths among males. So this suggests high rates of tobacco use in our population, a lack of early detection of lung cancer cases, and a lack of access to treatment options. Because I don't know about your jurisdiction, but outside of the major areas like Guam and a few other places like that, we don't have medical oncologists, we don't have radiation oncologists, we don't simply, we don't have surgical oncologists, we don't have the manpower and the equipment to treat these issues. So all of this combined together gives us very high rates of lung cancer deaths in the Pacific. So what are the risk factors for lung cancer? Well, I'm sure you can easily identify cigarette smoking as the primary modifiable risk factor. But there is also the issue of secondhand smoke for those who live in a household with a tobacco user, and this is particularly important for children. And also we need to talk about the issue of third-hand smoke, which is the tobacco that gets trapped in clothing and furniture and drapes and so forth, which exposes non-smokers to the tobacco and hence increases their risk of lung cancer as well, even if the smoker in the home is smoking outside, all right? Maybe his clothes contain cigarette residue, and that's exposure, okay? Now there's also the issue of environmental exposure to air pollution, which is a significant issue in growing urban areas across the Pacific, such as those that might be found in Suva, Fiji, or Port Moresby in PNG. Okay? And there's also the issue of indoor cooking fires, which can lead to chronic obstructive pulmonary disease and asthma, and which also increases the risk of lung cancer, and which is an issue in most of the Pacific, considering that we remain primarily a rural area and people continue to use wood fires, okay? And even in urban areas like where I come from in Suva, Fiji, in the settlements, even though we're in an urban area, people in the settlements continue to use indoor cooking fires as well, okay? All of those increase the risk of lung cancer. Okay, so now let's talk about breast cancer. Breast cancer can occur in men, but it's primarily going to be found in women. Now, globally, 1 in 8 women will be diagnosed with breast cancer during their lifetime. So if you look at the chart, we see that here in both Micronesia and Polynesia, we have breast cancer rates that are close to those of developing countries, or developed countries, I apologize, similar to those found in places like Southern Europe, where we see breast cancer levels at very high rates. Now, there are several reasons for the high rates in the Pacific, and this includes a linkage between breast cancer and obesity and physical inactivity. So in other words, the more obese you are, the less physical activity you have, okay, the more likely you are to have breast cancer. There's also been a number of studies that have looked at diet, okay, and specific forms of diet that we have here in the Pacific that may be high in fat, and those increase the risk of breast cancer as well. There are some studies that look at ethnicity, showing that certain ethnic groups are going to have higher rates of breast cancer than other ethnic groups, okay? And as you know, ethnicity is not a modifiable risk factor, but weight, diet, physical activity, the types of food we eat, those all are modifiable risk factors that can reduce the risk of breast cancer in the Pacific. So now let's talk about prostate cancer. Now, prostate cancer is the second most common cancer among men, and that is second only to lung cancer. Now, there are several risk factors for prostate cancer, including, once again, obesity, as well as rapid weight gain, as well as ethnicity. Okay, and in particular, diets that are high in meats and saturated fats tend to be those that are most closely associated with high rates of prostate cancer. Now, as you can see from the graph, Polynesia has prostate cancer rates that are quite high, in fact, approximating those that we would see in Southern Europe, so in like Italy and Greece, whereas Micronesia tends to have higher rates, but they still are high. Now, it should be noted that the burden of many cancers, including prostate, breast, and lung, are most likely higher than reported. Now, the reason for that is owing to low rates of surveillance, as well as low rates of individuals presenting into the medical system, and also then the third reason for these higher than reported rates would be that the true cause of death as recorded on death certificates is not always accurate, and one of the reasons for that is we simply don't do autopsies at a great level out here in the Pacific. All right, we don't tend to have a lot of pathologists, and so we tend to rely on surgeons to do the autopsies, and they're not always as gung-ho about doing those, okay? And that isn't just the Pacific, that's a lot of areas around the world. We have seen a drop in the rates of autopsies that are being performed. So in fact, if you look at this, it can be assumed that cancer rates for the Pacific are actually more likely higher than is being reported at this time. So now that we've talked about cardiovascular disease, and we've talked about diabetes, and we've talked about cancers, we can talk about our fourth target from WHO, or that of chronic respiratory diseases. Now, chronic respiratory diseases are a leading global cause of death and have high rates of underdiagnosis. So as such, rates are probably much higher than what is actually being reported. Now, I do want you to note that 90% of all chronic respiratory deaths occur where? Well, they occur in the developing world, in those low and middle income nations like we are out here. So this is why? Well, this is because of the higher numbers of risk factors that are going to be found in the developing world. Things like indoor cooking fires, increased tobacco use, and in many areas, increased exposure to pollution. Now, because of this, many chronic respiratory diseases are preventable. Now, total deaths from chronic respiratory diseases are expected to increase by more than 30% in the coming decades unless we take some type of urgent action now to reduce the risk. And the most important risk that we can reduce is tobacco use, okay, number one. And then out here in the Pacific, we can increase the risk of people being exposed to indoor cooking fires. We can modify the way in which people build their homes in rural areas. We can ask people to cook outside if possible, better ventilation and things along those lines. Now, chronic obstructive pulmonary disease, or COPD, is going to be a type of chronic pulmonary disease that's characterized by persistent blockage of airflow to the lungs. Now, the air that you breathe does what? It goes down your windpipe into your tubes and into your lungs through little tubes called bronchi. Now, your bronchi then branch into thousands of smaller tubes in the lungs that are called bronchioles, and these in turn feed into tiny air sacs called alveoli, and it's the alveoli that is going to be where the oxygen is going to enter the bloodstream, and it's also going to be where waste products in the form of carbon dioxide are eliminated from the blood as the air that we then exhale. So a person who has COPD has an obstruction in the amount of air that can flow into and out of the lungs. Now, one of the problems that we see in the underdiagnosis of COPD is that is oftentimes simply referred to as smoker's cough, okay? And so it goes undiagnosed. All right, and then the other reason that sometimes it's undiagnosed is it has a very slow progression, like many of our other non-communicable diseases. However, it's important to remember that COPD is actually a life-threatening disease that interferes with normal breathing, and once it's progressed, it cannot be fully reversed. So public education, all right, and screening programs are particularly important in terms of, preventing COPD if possible, but also identifying individuals in the early stages of COPD so they can receive the treatment that they need. Now, as you can see from this slide, COPD is a global public health issue, and it impacts over 65 million people. And once again, we see that we have a disproportionate burden in our low-income countries where 90% of the cases exist. Okay, and it's also, once again, important to remember that in our low-income countries, that's where we see the high rates of tobacco use and smoking, and also exposure to indoor air pollution. So once again, what are we left with? We're left with a situation in which there is significant room for prevention, especially here in the Pacific. Now, asthma is also going to be our second form of chronic respiratory illness that we're going to talk about. And asthma is characterized by chronic breathlessness and wheezing, where an individual struggles to intake oxygen and the airways become constricted. Now, the lack of oxygen and the frequent asthma attacks can actually leave a person feeling tired and without energy to perform their daily tasks. And that's that debilitating effects of the NCDs, or the lack of quality of life that we talk about. And we know that here in the Pacific, once again, we've got people that are doing what? They're using indoor cooking fires, okay? And so I know that in Fiji, we see a lot of kids that miss school because of asthma, all right? And if they're missing school because of asthma, they're not getting the education, they're not going to be as economically productive later in life, and once again, they're going to fall into that poverty cycle that reinforces NCDs, reinforces poor lifestyle decisions, okay? Now, like it says there, globally, asthma impacts about 235 million people, and it is the #1 chronic disease among children worldwide. And once again, it tends to be underdiagnosed. Now, very few people are actually going to die from asthma, but of those who die, and listen to this, of those who actually die from asthma, 80% of those deaths are going to occur in low and middle income nations, such as we have here in the Pacific. Now, individuals diagnosed with asthma, we can treat them with medications such as bronchodilators and things like that, as well as lifestyle management. And lifestyle management involves avoiding risk factors that might trigger an attack, such as exposure to indoor air pollution, limiting exposure to tobacco smoke, and so on and so forth. It is a chronic illness. You know, once you've got it, you've got it. Okay, but we can limit the impact. So in other words, we can engage in tertiary prevention with these individuals. So we've just concluded discussing the main non-communicable diseases, the 4 main ones that WHO wants us to place an emphasis on, and we've completed discussing their risk factors. Okay. Now, as we've learned, these NCDs oftentimes share common risk factors such as diet, exercise, and in particular, overweight and obesity. So the question becomes, why should we collect data on risk factors for NCDs? Now listen, what did I say? Okay, notice what I said. I said risk factor surveillance, not necessarily disease surveillance. Now, the commonality of the risk factors means that if we can control issues such as obesity, then we can control the risk of populations having higher rates of cardiovascular disease, diabetes, cancer, and even to an extent the chronic respiratory illnesses as well. Now, in countries around the world, disease-only surveillance systems have been developed for communicable diseases. So for things like dengue, typhoid, Hansen's disease here in the Federated States of Micronesia, tuberculosis, and so on and so forth. Now, we're all aware of these systems in the Pacific, and we've been using the communicable disease surveillance systems for decades, if not longer. However, as you are fully aware, we're undergoing an epidemiological transition, right, where we still have communicable diseases, but the major burden, the major source of morbidity and mortality is now the non-communicable diseases. Now, we can see other countries that have undergone this epidemiological transition, and China would be an example of this, and they have seen the burden shifted, and so what they've done is they developed NCD surveillance systems that monitor conditions such as injuries and cancers and so on and so forth. Okay. However, I want to point out that surveillance for NCDs can be difficult because there's a lag time between when an exposure occurs and an actual disease happens. So we have to ask questions like, how long does one need to smoke before lung cancer or before they become a lung cancer patient? Oftentimes it's decades, okay, and it varies. Some people never will. But a large percentage, it takes years for them to go from being a smoker to being a lung cancer patient. We can ask questions like, when an individual is diagnosed with when is the individual diagnosed with a health condition? Is it clear how much time has to pass since exposure occurs? As well as what confounding variables may have been involved in the disease. So if we're looking at lung cancer and smoking, we have to ask questions like, when did you start smoking? How old were you? Did you always smoke the same number of cigarettes per day? Was there a time period in your life when you attempted to quit smoking? Did you work in a factory where you might have had exposure to asbestos and so on and so forth? All of these elements are hard to control and account for over long periods of time if we're doing disease NCD surveillance only. Okay, and this element of confounding an exposure is particularly tricky. So for example, genetics, obesity, lack of physical activity, smoking, occupational exposure, these are all factors that can increase the risk of cardiovascular disease. But they are also factors that increase the risk of type 2 diabetes and chronic lung disease in some instances. So it becomes clear that what we need is prevention. All right. Now, interventions that target risk factors must be based upon data drawn from disease surveillance. So in other words, when it comes to non-communicable diseases, surveillance based upon disease is less effective in developing surveillance. Surveillance based upon monitoring risk factors in the population leads to better interventions and hence a reduction in the NCD burden. Now, I hope this makes sense, okay? Because what I'm saying is that in regards to NCDs, our epidemiological surveillance should look at risk factors. Now, that is not to say that we shouldn't collect morbidity data, okay, or mortality data on how many people have a disease, but that we should also focus on risk factor surveillance as well. So this would include things like smoking rates, dietary intake, height, weight surveillance, community surveys to see if they have access to healthy food options and markets and so on and so forth, so that we can develop an epidemiological picture of what are the risk factors and how much of our population is at risk from those risk factors. Because once we know the risk factor, we can come in and we can develop intervention programs that reduce or remove the actual risk factor before the risk factor becomes the disease. So it is clear that behavior plays a critical role in the development of health conditions, many of which can lead to early death or disability. So because of this, it's imperative to change people's behaviors and practices to reduce the risk of developing an adverse health condition. Now, if we can do this, this is going to ultimately lead to a reduction in the burden of NCDs that we have in the population. Now, to implement an effective intervention program, it is necessary to have information on the distribution prevention of risk factors in the population. So surveillance of risk factors is essential if your goal is to reduce the burden of NCDs in your population. Let me say that one more time. Surveillance of risk factors is the essential key for you to determine the potential burden of disease in the population, and hence develop interventions. I hope that makes sense because it's very important. Well, there you have it. You've made it through the second lecture. So what do you need to do to get credit for this lecture towards your certificate of professional practice in the epidemiology and control of non-communicable diseases? Well, send me an email. You can see my email on the screen right there. And in that email, please include your name, where you're located at, your job title, and here's the important one, the 3 things you learned from the lecture that you can apply in your job. Now, keep the 3 things simple. A sentence or 2 for each of them is all I require. Now, once I receive that information from you via email, I will record your participation, and then you are set and ready for the next video lecture, okay, which will be released a month from now. Okay. Now, as always, thank you for your participation. You know and I know that without your willingness to work hard every day and to take the time away to improve your skills through classes such as this, that there could be no public health, there could be no medicine in the Pacific. So to you, I say thank you and well done.